proposals that have already been generated, either by individual proposals or have been discussed in a small work group around funding. And then we have a few other folks who want to bring up some issues toward the end. Kristen had asked for a minute and Pete had asked for a minute. We'll see if there's any other pending action items and adjourn. So that is our goal for today. I just want to say up front, and I think everybody here probably feels it, this is a bit of a difficult group to figure out how to organize and how to approach the work. I think part of it is that everyone is genuinely and legitimately frustrated by the situation. And that comes through in trying to figure out what's the right problem solving. We've gone back and forth as a group around, should we talk about things by grouping them by subjects? Should we talk about them by grouping in sense of urgency? And people have different opinions on that. We will be reaching out to folks who have a sponsored proposal in the queue to get a better sense from them if what they think the timeline is for enacting this is, and I'll probably be doing that with you over the next couple of days. And the other thing that we've gone back and forth over, I think, as a group is how detailed are these proposals? If we're using the proposals to launch our conversation, the expectation is that a proposal would be pretty well thought through with a fairly high level of detail. And is that how we want to work? And I get the sense that some people do, but then I get the sense from others that they prefer to use their proposal to generate an idea, and then they want to work in subcommittees. So we're grappling with all this. I don't pretend today that we have exactly figured out the rhythm of the group. So I think let's work through our first group of proposals combined with that first report from a subcommittee. We'll all keep trying to make sure our time together is very productive and moves forward. But I just wanted to acknowledge that all of those sort of factors and thoughts have been in play and have been communicated back and forth over the last couple of weeks. So having said that, let me turn to Jeff Davis to see if he has any welcoming comments or any updates that he wants to share with the group.
Jackie, thank you. I do understand that Gary is actually with us, but struggling to unmute. So we can consider that fortunate or unfortunate. I'll let everybody decide. So I'll just give a couple of quick updates on the ARPA monies, which may well work themselves into this conversation or separately. And that is we'll see an administration-wide response to this among human service agencies. Stakeholder input will be critical. It will be essential by design into how we move forward. So we are, as a group of agency directors in the human service area, working on a sort of an online survey, so to speak, or whatever it might be, that allows anyone and everyone to submit suggestions on how to use these ARPA monies. And I'm talking about the ones that, for example, that we generate off the enhanced death map, that Medicaid aging, and how we do that. So we should see something out shortly, I hope, meaning within the next couple of weeks, that literally gives stakeholders, whether individually, collectively, an opportunity to make suggestions on how to use these federal one-time relief dollars. And then the legislature themselves will be important to this process. That's necessary to keep in mind, because ultimately it will take legislation both to appropriate the money, to set up the accounts within the different departments so that we can spend the money. And given it being a legislative process, I'm sure that advocacy and input and their interest in one way or another and how these monies are spent will be part of the puzzle too. So you should see something. I'm giving everyone a heads up so that you can start to think or rethink about what you might have submitted already or what you might want to do together or whatever it is, so that stakeholder process can be most beneficial and profitable.
Great. Okay, well, that may be the perfect segue into our first presentation today. You'll remember last time we started looking at our first proposal, which was a financial incentive for new employees, is how it ended up being packaged at the end. And after some discussion, the DSP work group offered to look at that and think about overall, beyond even that proposal, what are some financial incentives for new employees. So Teresa's work group took that on, and I know they met, and I know many of you were involved in that. So for some of you, this is review, and for some of this is new information to digest. So Teresa, where are you at, and what do you want to propose to this group? So the floor is yours.
All right, I am here. um, and yeah, so we met last week, and I, had a really good discussion about lots of different possibilities. I think where we, in the interest of time, I'm happy to share those notes. Jackie, I know, share them with you if you want to share them more broadly. But we spent the first probably 20 minutes just brainstorming different ideas. And then really started to refine some of those and came down to some short-term ideas and longer-term ideas. And so Jeff's right, Director Davis is right, that our short-term or immediate ask really revolved around the use of the ARPA funds. The group thought that that was the quickest fix, if you will, to address the immediate or urgent crisis with a plan, knowing that those are short term, not sustainable. And so they're needing to be kind of a corresponding longer term plan. And basically, with this idea of developing some sort of consistent model for the use of those funds across providers to be able to use those for example, and these are not details, these are just these were not agreed upon, just examples of what might constitute a model. So if somebody was going to use those dollars, they could use them for sign-on bonuses or incremental, like 30, 60, 90-day bonuses. Jason has been really great at reminding us that yes, we need to get people in the door, but we also don't want to quote unquote waste those dollars. So if we're giving them at the point of sign on, but then they leave in a week, or at 30 days and they leave at 31 days, which is what people are finding, that that's not the best use of those dollars. So the model would somehow include kind of when or how those could be distributed to people under, what conditions or what terms that would be a statewide model, certainly with some flexibility for providers, because Debbie also reminded us that if other people are giving sign-on bonuses and we can't give sign-on bonuses, kind of how can we compete with other higher employers? So still plenty to think about and flesh out in terms of what the details of the model might look like, but something that would be agreed upon to use, like I said, statewide in the short term. Meanwhile, kind of immediately beginning action on, and also to be used for marketing purposes to really kind of promote the DSP workforce and the need for employees. And then Bethany too has brought up a lot this using those dollars also for bonuses or some mechanism to reimburse or reward DSPs who stayed through the pandemic. So we don't want to give a bunch of cash to people who have been with us for 30 or 60 days, but not the people that have been there 5 years, 10 years, and who stayed through, in particular, this past year. So those would be sort of the ARPA or short-term thoughts. And then longer term, again, beginning immediate work on looking at the rate model and some different ideas of what could be possible within the rate. So some things like looking at what an initial pay could be that would actually reflect someone's education and experience or some specialty or specialization that they have, instead of having to bring everybody in and get reimbursed sort of at the same base rate. Looking at ways within the rate to allow for increase, just basic kind of cost of living increases, raises, career advancement. If somebody is, gets a degree or has a certain specialty. And then also something that would allow us to take a look at the scope of work of a DSP and whether there would be specializations based on providers or even on individual DSPs. So for example, maybe there's somebody who has a special skill in supporting people who have some medical complexity out in the community, that takes a different skill set, recognizing that takes a different skill set than maybe somebody who has really complex and challenging behaviors out in the community, that those are two different skill sets, both are needed. And how could we recognize some of those different specialties and the skill sets that it would take and reward those financially. So those were just some of the things that as we would open a discussion about a rate model or reimbursement that would be factored in. So that was the longer version. The shorter version is the short-term ask would be the ARPA dollars. The long-term ask would be opening discussion about the rate model.
And Director Davis, if I may, based on the conversations we've had recently about legislature coming back, the need for something to be passed and the ARPA dollars being available, late third, if not fourth quarter, a 90-day, 180-day reward, if you will, a universal agreement on how those funds are to people who come in new based on their propensity to stay, not just sign on. It is something, team, that we could put in place literally in the next 30 days and not have to worry about shelling out the dollars, because the dollars wouldn't be earned for 3 months after people are hired anyway.
Any other thoughts or questions from those of you who were in the group or who are hearing these ideas?
This is Willie. Teresa, in your group, was there any discussion also about incentives to retain people, not just for the recruitment, but to retain them?
Yeah, so Willie, at the end, we kicked off by focusing on recruitment because that was what we had understood at the end of, as Jackie said, the end of our last task force meeting, that our focus was recruitment. We absolutely recognize that those two things, as Bethany, I think, said, that the moment they sign on, it becomes a retention issue. So, the recruitment is one thing, but then retention becomes immediately applicable. And so those were some of the things, like the bonuses or building a rate structure that actually allows them to get raises or recognizes educational accomplishments or special skill development or things like that. So it was not as robust a discussion around retention. I mean, I'm sure there's plenty more that we could do around retention, but we recognize that they're linked.
Because in thinking about the ARPA funds, I'm also looking at the current workforce. And if somebody new gets a bonus and our current employees don't get anything, they're going to be disenfranchised and have a greater reason to leave versus stay. So where that fits into the task force, on what do we do to keep those current people?
Yeah, so that was part of our ARPA dollar proposals, was the bonuses both for recruitment and for the people that stayed.
Yeah, so I think there still needs to be work done on it, Teresa, right? I mean, we've met a couple times, but these are really just brainstorming and needing to be able to better refine it. But I believe that there was consensus of most of the people who attended that we probably need to look at a way to be able to provide some type of financial incentives or bonuses to people who are providing the direct support services. And use those ARPA funds to do that. And so I know, Director Davis, you mentioned that the state is going to do kind of a statewide look of the ARPA dollars. I guess the question is can we, would we have to submit this proposal through that, or can we work through this group to try to better refine that and come up with a proposal on how we could use some of those funds?
Debbie, try that one more time.
So this group that's been meeting, we've been talking about, DSP compensation, right? And in the short term, what we'd like to be able to do is to define some type of a compensation type package that we could provide to direct support professionals, around, getting them to kind of stay, right? Or bonuses for the fact that they have stayed, right? And the funding source for that we're suggesting would be the ARPA dollars. Given that you've said that the administration is kind of doing that at administration level, and they're going to be requesting for stakeholders to provide input into how to use those funds,
Yes.
would we need to do this submission through that process with the administration, or can we continue to work through this process within DODD, to submit that request on how we utilize the ARPA funds?
Yeah, I'm not exactly sure. So without question, I think it would be advisable to use the process that the administration sets up. But I think that's doable. I mean, I think that's eminently doable based on what you're working on here. But I guess I'm not following. I mean, the sort of collection and collation and all the summary, will go through these submitted requests. So, but
So
that does,
So Jeff or Director Davis, I'm sorry.
yeah, it's just,
Um, so it's not either or, it's both and, is that correct? So the DSP working group could work together to come up with a proposal and we would submit it through that process.
why not?
And you probably should submit it through that process.
Yes. I would say affirmatively, if the anticipation is using ARPA dollars, then absolutely. I mean, we're going to continue to talk about things and we'll share them and you will in different ways, but without question, use the administration process to submit requests as well. Did that make sense?
So if I can add, so it sounds like when we were dealing with COVID and vaccines and looking at our phase 1B and the vaccines were going to be available, right? We established a kind of a system on what we're going to do to help get those 1B people vaccinated. So we're kind of talking about the same thing with workforce to get access to those monies. Pretty much the same process, right? Same model. We're having a plan up front, so when it's available, we have an easy way to access the funds.
Well, I'm pretty intimate to both of these things, but I'm struggling in both you and Debbie to understand. So I'm so sorry. I mean, I know that something I'm missing here.
So I think, Jeff, what they're saying is we probably have to do a both and. This group, whether it's, under Teresa's name or however we figure it out, this group has to submit its proposal for ARPA funds through that survey process. But at the same time, since it's part of the task force, you can be promoting it.
Yeah, of course.
Well. So it's really a both and, but we need to formally submit. We don't get to bypass that online process just because you're here, is what we're saying. So we have to do a both and.
That would be correct.
Okay.
Wouldn't want to bypass that piece.
Okay.
And it's very simple. I mean, it's not going to be time consuming to submit through that portal or process. Not going to be. But you're going to want to be in the mix through that formal process for sure. And then, of course, whatever we come up with together, I mean, yes, that's all a given.
So Teresa, did your group, and I know you had one meeting, so I'm not trying to put too much weight on your shoulders here. Did your group discuss how do we get from these ideas, some of which have been, discussed here already, just a tiny bit, to a more detailed version of this is the model we want funded and we think it would cost this much, and we know that it's kind of one-time money, so how does that play out? How did you guys envision getting to that level of detail? Or did you not really talk about it?
We did not. Again, I think there was consensus around a model. I think there was consensus around the both for kind of recruitment and retention. And but that would, and using the ARPA dollars. And so I know Jason has a much more thought out proposal. He might have done cost projections. I know that you put a lot of time and thought and have been thinking about it, Jason. But I mean, I think we could certainly reconvene if that's still the group that makes sense to do that. If it makes more, I mean, if there are other or different people that make more sense,
To respond to the inference, yes, I do have a model and a suggested model, but we never got to that point as we discussed during that first call because it went in all different directions.
So well, I guess what I'm trying to figure out is, where do we do a small group, and do we let them, you know, like hone in on a proposal or a process and bring it back to all of us? Or I'm trying to figure out if this subcommittee process works, or if we end up with all the same people on this call in your subcommittee and then we're being duplicative. So just trying to figure out what's the right go forward, because this proposal is probably the first of many that could flow over the next few months. So how do we want to flesh it out and get it into something where it's detailed enough that people can say, I like that part, I don't like this part. If we put this part in, it costs X. We take that part out, we save Y.
Jackie, I thought what the point was, and maybe I misunderstood how we're doing this process, but I thought what I understood from this process is that we were going to use this template to kind of be a quick overview of what a suggestion or proposal would be. And then the group would vote on whether that was something we wanted to explore further in depth. And so
Right.
then we would have subcommittees that would look at that. If we agree that's what we want to explore further in depth, we would have a subcommittee that would work on that and refine that proposal, or work with the department if it's something that the department needs to do changes on, and then we would work on how do we implement it at that
Debbie,
point.
that was the original, and I'm just trying to be really transparent with everyone. That was the idea. Last time after Jason proposed proposal, people sort of resisted having to vote, and we decided it would go to a work group. So I'm trying to check with the group if we still want to follow that. I think that does put a little more onus, and I might have to circle back with a few of you who've turned in proposals, because some of the proposals that have been turned in are extremely high level. Like, even to vote on something, they're so high level. So the proposals would have to be, at least in my experience, you know, when I worked in government, proposals would have been a little more fleshed out, quite frankly. So I'm trying to figure out from the group, where do you want to go with this? Do you want to vote on some specific proposals, which was the idea? And then last time everyone was like, oh, but Jason's idea rolls into something bigger, so we should go right to subcommittee. So I'm a little betwixt and between, trying to figure out what's the will of this group so that we're efficient. But
And I thought the vote
was the original construct.
Yeah, I thought the vote was just on whether we wanted to explore it further, knowing that these things were not going to be super well defined, because it would be something that we'd want to have more input than just one person's thoughts on.
And that was the idea, that it would be a two-part. What is it, an idea worth further exploration? And then after there was more detail on it, do we want to vote as a group that we have consensus it should move forward? So you're right. But some of the proposals are very, I'm just saying, maybe it's my own judgment, they're very high level concepts. So if that's the way the group wants to go, that's how we'll roll. But so we would need to vote, and I know Pete's got his hand up. We would need to vote then on this incentive package, and do we want to go further? Pete, let me throw it open to you. And I apologize if I'm the one who's out of sync here. It's been known to happen. Pete?
I think this is a no-brainer. We have to move forward with retention and supporting direct care staff to stay on the job and trying to get more people in. This obviously has a lot more flushing out to do. We're gonna have to bring numbers guys in like Clay and others at this point, I think. to start to put together some real numbers on what it could look like, the criteria. To me, for this group, it's a no-brainer that we move forward and get it, whoever we need, whatever expertise we need to move it forward as quickly as possible.
And to follow up on that, you give me no more than a half hour to an hour with Clay or Rivo or a combination. I'll put actual numbers and data. If they could give me one piece of data, I could tell you how much this would cost the system. It's flushed out. We just never had time to sit down and go through the details.
Okay. So what I'm hearing is on the incentive for new employees, and I don't know if we want to break it, Jason, into two, and Teresa, if it's incentive for new employers or if we just want to now say incentives for DSPs, because you described sort of a two-pronged process. Would you have a suggestion, either one of you, for what the title is on the vote to proceed? Is it incentive DSPs?
I don't think you can make it just DSPs because we've got too many categories of STNAs and med techs and everything else. But I do think there is a way to combine the proposal into new and existing so that the provider gets the cash in my proposal in detail, and they determine how it's distributed. Because as Debbie has said, people are already doing similar things and you don't want to disenfranchise them. I've combined everybody's concepts of my original idea already. So I've got something. It's a matter of putting it together.
Excellent. So the current proposal, then we'll go to Debbie, she has her hand up, is incentives for new and existing staff, as described by Jason and Teresa, moving that forward to put a finer note on it. Debbie?
I just wanted to point out that we have to remember that the ARPA funds are only available for home and community-based services, that we would need to also have a request for the state and local ARPA dollars for our ICF providers if we were going to do this for all providers within the system. And I would suggest that we need to do it for everyone and not just for one group of direct support professionals.
Concur.
Okay, so I know this might seem redundant because I suspect that most of you are in approval, but we do want to get a rhythm on some of these as we come down the pike. They might not all be in so much agreement, so we do want to start establishing a process. So I believe the vote I'm about to call is that we are in consensus to further develop a proposal for incentives for new and existing staff, correct? And Jason and Teresa, I'll look to you if you want me to reword that.
So Jackie, I think Gary Talks has his hand up.
Oh, I missed it. I'm sorry, Gary.
I don't know if he can unmute himself and talk. You might have to hit *6, Gary, to unmute yourself since you're on the phone.
Hello.
There he is.
Nah.
Go ahead.
Oh, I feel like the Verizon guy. Okay. So I just want to remind folks that we have independent group through shared living that are causing some stir right now. So I'd like those to be included somehow, even though it's a daily rate. I don't want to forget about them.
Okay.
So, can I, Gary, did you, you broke up a little bit, or maybe I did, but did you say shared living providers? But not all independent providers? Is that what you're?
I would think it would encompass all.
That was my sense from Jason talking a little bit ago, that it was looking at new and existing staff and all kinds of staff.
Okay, so on the group, the consistent, I mean, if this is where people want to go, we've consistently talked about independent providers, and consistently on the group, it's been commented that they make enough money. So if that is not the consensus of the bigger group, that's fine, but that should absolutely be a point of discussion then, Jackie, is because I think that is a different sense than
It's a
And then
different
where the
proposal.
crisis exists was with agencies. So I'm not for or against. I just want you to know that's different than the conversation that we've been having in the other group.
So Teresa, maybe that's just a point of discussion on the scope as the proposals developed further.
That's great.
Okay. All right. So I want to do a quick roll call, yes or no. You're in consensus to move forward to develop a more specific proposal to secure incentives for new and existing staff. Jason? Yes or no?
Yes.
Kristen?
Yes.
Debbie Jenkins?
Yes.
Willie?
Yes.
Kim?
Yes.
Teresa?
Yes.
Pete?
An enthusiastic yes.
Julie? I'm not sure if Julie's short. If she's
Not
joining
till
us next
August.
meeting.
Next
Yeah.
time.
Okay. Janet?
Yes.
Bethany?
Yes.
Gary? I know he probably has to unmute again. Gary, whenever you unmute, we'll get your vote. Nathan or Nate?
Yes.
Jason? Scott? Oh, that's right. I'm sorry. And Renee, I haven't seen Renee join the call while we've been talking either. Okay. All right. So the process is to keep moving forward. So the process, are we going to put Jason on point for this or Teresa on point? And I know in some place it'll start to blur because you'll all, call in who you need. But Jason, are you taking point for further fleshing this out and reaching out to who you need to? Pete has his hand up as well.
Well, I'm in a car, so I'd put my camera on, but you'd see the ceiling of my car. I'm happy to detail the very specific proposal and echo the variables that are up for debate and moving around based on everybody's input. But I will need help from someone at the state and probably the associations to get an estimated number so that we can quantify what the potential cost will be. Now, these are round numbers, but I can't do the cost analysis by myself, but I can put together the proposal in detail and then send it out. But I don't, again, this is just my preference. I think more than 4 or 5 adults in a room really degrade the amount of progress we can make. So if we could keep it under that, that'd be great.
All right. So Pete, let me get your input. Your hands up.
I was just going to recommend Jason meet with Clay and whoever else from the department, flush out the numbers. We can try to get the numbers that Jason's talking about. Then possibly bring it back to the Teresa group for just review and prep for our next task force meeting. My suggestion.
Jason and Teresa, how do you feel about that proposal?
I love it.
And Clay and Rivo and some others, you're available to assist?
Yes.
Okay. All right. So I think we have a plan on this proposal to move forward. Thank you for helping me work through a test case with a very important proposal. Appreciate that. I don't know, again, Teresa, I know you guys had a broad-based conversation. We have 3 other proposals that you may or may not have sort of touched on in those conversations. So feel free to either chime in or redirect me. The next financial proposal that we had in the queue was submitted by Pete, and it was about funding the community through grants. So I don't know if you touched on that in the work group or if Pete's introducing the concept to everyone.
We did not touch on it.
Okay.
Or if we did, Pete. I didn't capture it in my notes.
No, we didn't touch on that. I think the key is how do we, the very short explanation is, given our workforce situation and where we've had discussions about, only being able to provide the bare minimum of services to provide health and welfare, that if in fact we want to continue to provide community-based services in some areas, that we would need extra help to be able to make that happen. So I'd certainly have to flush it out some more probably to get ready for this committee, but it was just filling that gap and trying to get additional funds to provide some services for folks that may be missing out on some stuff. I'm happy to get some more detail around that to have a further discussion. So just as it was one of a few proposals.
Okay. Does that sound like the next step then? You're going to flesh it out a little bit more and then bring it back? Okay. And Pete, I know a couple of people who read this did mention to me that and again, this is where I'm not a content expert and don't do this every day like you do, but that you either had done something similar or there had been a similar program before. And so they were asking what the differentiation was. So when you think about it, and again, I don't know if it's those are finished and this is starting anew, if it's a funding source, but I just throw that back to you because someone made that comment or submitted that comment to me.
Did they say what program they're talking about?
They just said that there have been programs of these community grants. So why is this different? And literally that's the extent of the comment. So
I'm not proposing that it's different. If there's something similar out there, let's keep it going.
Okay.
So whoever made that comment, let's take a look at it.
Okay.
So it wasn't me, but potentially was it maybe some of our grants on the day service side for the smaller group settings that we did previously? Because I'm not aware of any grants on the residential side for this type of a thing. Does anybody from the department know any other grants?
Otherwise, Pete, I'll try to go back through my notes and figure that out for you. All right, so this proposal, everyone hears the concept. Does anyone object to Pete further fleshing this out to come back for consideration? Sounds like a plan. Okay. The next proposal, and we will loop back to Teresa's longer term idea after we work through these two formal ones. Nate had submitted a proposal about expanding longevity and complex care add-ons was the title of his proposal. So Nate, the floor is yours.
Yeah, sure. Thanks, Jackie. So the essence of my proposal is based on a piece of dialogue that we had at the very first meeting of the task force, where we talked about, I think, specifically some of the complex care add-ons, the longevity credits that the providers may not be using as intended because they say they're too difficult to bill for. And I've had some separate discussions with members of OSDA, Christine Brown specifically, about the possibility of having these add-ons apply to more HPC services or all of the HPC services, because she was with the understanding that they were specific to routine HPC. And my understanding is that Ms. Brown had conversations with Debbie Hoffline, and maybe if Debbie is here, she could kind of elaborate a little bit, but that the department intends for those credits or add-ons to be reimbursed as not just routine HPC, but all of the HPC services. I don't know if Debbie can kind of elaborate a little bit on that, because there was a bit of a misunderstanding.
Sure, I think I can make a couple comments. And so just to sort of level set first, we have several add-ons within the waiver programs, but two in particular that I want to make sure we're talking about the same things. So there is a complex care add-on. The complex care add-on is based on qualities of the person being served, and so it's not DSP related exactly, but and it's also very prescriptive in rule about what qualities the individual has to have in order for the provider to get that complex care add-on. But the competency-based add-on, which I think is mostly what this conversation is geared at, is based on the training and experience of the DSP themselves. And we have heard from provider agencies, particularly those agencies who are doing services in group settings, group home, 4-person settings, 3-person settings, that sort of thing, where individuals are sharing services, and the agency is billing that through a daily rate. It does become cumbersome for them to track the workers in a way that allows them to use that add-on to their advantage. So I think Janet Steffen, I think I said that right. And so
it was perfect, Debbie.
Thank you.
Thank you.
And so we are and so in the context of the competency-based add-on, we are looking at it through several different lenses, and I'm certainly paying attention to this conversation. I think when we talk about it only applying to routine homemaker personal care, that's saying it doesn't apply to on-site on-call services, which are when the worker is permitted to be asleep. And so right, wrong, or otherwise, I think that's some of the distinction and when we apply the add-on and when we don't. And again, that's certainly what I want to say. It's all up for discussion and review, and if we need to make rule changes and that sort of thing. But that's how it sits now. So okay. If we need to consider changing that, of course, we have to look at the budget and all that goes with increasing our services. And we do have rate increases coming the first of the year, and so there'll be lots of changes in the world of rates as well. But I'm definitely interested in seeing what recommendations this group might have around improving those add-ons. So does that help, Nate?
It does. Thank you.
Hey, Debbie, this is Gary. Can you hear me?
Yes.
Oh, it works. So I have challenges with what constitutes complex care. I know you have
challenges, Gary. Thank you. Oh, I'm sorry. Yeah. What?
No, with the complex care. I mean, some of this stuff will be basic. You can't hear me. Okay.
No, we can hear you.
We can hear you. Okay.
Oh, okay.
We can hear you.
Oh, okay. So there are a couple comments. The complex care need add-on is too, as you said, prescriptive. So someone that needs assistance transferring but can do okay once they're on the toilet doesn't qualify. Someone who can pick up their food but can't cut their food doesn't qualify. So we've got those issues. But I may be misunderstanding. I don't think a DSP qualifies for the behavior add-on or the med administration add-on unless the specific individual they're supporting has a behavior add-on or med administration add-on. So there are challenges in that our DSPs serve multiple individuals, and they only get the add-on when they serve that particular individual. So it's not and also I may misunderstand, but there are no competency. There's no skill set that a staff person doing behavioral therapy has to have. It's the individual gets the behavior add-on, and if the agency wants to train them, they can. But there's no requirement that the staff person have a competency. It's only the individual has the add-on, if that makes sense.
Well, again, we have several add-ons. So you are correct. The complex care add-on, the behavior add-on, and the medical add-on are based solely on the qualities of the person being served. And
Right.
yes,
Right.
the agency provider or the independent provider, whichever, would only get those add-ons when serving the person who qualifies for them. There is another add-on, which is which we call, I think, the competency-based add-on. It may have a different name, but some people call it the longevity add-on. But it is.
Right.
It's solely based on the qualities of the worker, which, and I will say out loud to all of you, it's the most difficult for us to handle, so to speak, from a systems perspective, because we don't know who the DSPs are. It's easy for us on the independent workers. So an independent provider, they tell us, here's all of my training I've had, here's my experience, and we mark them in our system as eligible for the competency-based / longevity add-on. But for all those workers out in agencies, we don't know who they are to know if they qualify for the add-on or not. The only way that happens is if their agency provider bills for it because they know. And again, when that rolls up into daily billing, it becomes more difficult sometimes for the provider agency to track and do that properly. And I'm hoping Janet's got her hand up because she wants to help me here.
I do. I always want to be helpful. I think the discussion of add-ons is really important, but I wonder if it's more productive in the context of looking at the rate structure. I've heard that alluded to in different places with proposals, and I know certainly it's part of a proposal the provider associations put together. I just feels like to me it will make more sense when we look at that if we're examining, the duties that people providing HPC as it's currently provide, looking at appropriate rates of pay. And I think in the past, add-ons have been little band-aids to try to patch it. And I can tell you that add-on or not, they are not going to move the needle in the short term with workforce issues. But again, I think it's important to talk about in the context of looking at rates and looking at expectations. I hope that was helpful, Debbie.
You were always helpful, Janet. Thank you. So back to the bigger group, I guess, but I think I would be inclined to agree that as we look at the reimbursement structure itself, and I've said this a couple of times too, we have a very, very, very broad definition of homemaker personal care. And so that's partly why, these little Band-Aid add-ons were included, because it's a way to try to say, but if you're serving somebody with some more challenging needs, medical or behavior or whatever, we'll try to reimburse a little higher for that without changing that base definition. It all still fits in homemaker personal care. That may or may not have been a good approach to all of that. So I do agree that it's something that should be looked at. I do put it in the more long-term bucket, but that's just me. And again, it's your group, so I'll stay tuned.
Debbie, is there, and I know there's several rate issues kind of going at the same time right now. is there already a group looking at this that we should put make sure we have a few of our folks on and get aligned? Or is there another way you would tackle this ongoing discussion? You know, Nate said in his proposal that he recognized this wasn't probably a short-term fix, but how do we feed his thoughts and the thoughts of others into whatever working group or whatever pathway you have?
The work group has not been formed yet, but we are planning to hire or put out an RFP to bring in professionals to help us through the look at our reimbursement system in its entirety, which is our, ODDP and our AAI that establish budgets, and then our rate structure behind all of that. So that RFP is not out yet. We are in the very, very infancy planning stages of it, but that's something we have planned for this fiscal year, is to get someone on board to make a coordinated effort, which would involve, of course, all of our stakeholders. And so no, there's not a work group yet, but it's coming.
But that's the vehicle. So we need to figure out a way to, once that rate expert is on board and that process is identified, to make sure I'm sure these ideas will feed in, but to make sure that these ideas feed in at that point, that's the best way to move forward. Okay. Does that sound okay to you, Nate?
It does. And I would be more than happy to volunteer to be on that work group as well, since I benefit from some of the add-ons and it was my proposal. So.
Okay.
Jackie,
yes.
There's a question in the chat. Is it okay if I?
Sure. I see Renee just put it in there. Go.
So I tried to say earlier, I might not have done very well. If the add-ons are being paid to an independent provider, then yes, we can assure that it's going to that independent provider. If that worker is an employee of an agency, we do not, as a department, know what that worker made. And partly it's because pay structures, I think, vary from agency to agency. So some agencies just may pay everyone with 3 years experience more than they pay someone who just came in the door, add-on or not. So, but anyway, our data that we have regarding how agencies pay their workers doesn't tell us who's getting what. So I think that answers the question.
And Kim just posted a question.
No, it wasn't really a question. I was just saying that I just redid the ODDP yesterday for my son, and he currently receives the complex need and medically fragile add-ons, and the ODDP does not capture him as a person at all, except for the complex need section where every bucket was checked, yes, so that qualified him for complex need. The ODDP appears to me to be slanted toward behaviors and some people's inability to do specific tasks. But for someone who is total care, and we've got a lot of them in our system now, the ODDP is quite deficient in that area. So I welcome the fact that Dodd's going to open that up and start a work group to look at it, because it's been needed for quite some time.
I don't think you'll get any arguments from anyone in this room about that, but yes.
Okay. So it feels like we have put a path forward to examine this. It's a little more of a longer term examination, but Nate, you're the sponsor, so I want to make sure you feel comfortable.
Oh yeah, no, I'm totally fine with a longer term process on this. I fully expected that it would be a long term process.
Okay, thank you. The next proposal then that we wanted to look at was a joint submission. I think we had put, let me see who we put on point to discuss it. We had put Debbie on point to discuss it, and it was about DSP compensation. And in the chat room, you'll notice there was comments about some of what's in that proposal reflects some of the longer term conversation that was happening in the work group. So we'll see if they come together or if we need to have two conversations. So Debbie, you are up.
Thanks, Jackie. Really, this proposal is, trying to get at, the basis of what we feel is one of the major issues with our ability to hire staff, right? It's about our reimbursement rates and how much funding is available based on the work that direct support professionals have to do, and what we ask of them. And so you guys will see, if you read it, there's really nothing new in here. It's what we've been talking about for a long time. We think we need to look at the reimbursement. We need to look at what we're funding and what we're requiring, and are those two things going hand in hand? And so I feel like this falls pretty in line with kind of the longer term conversation. I would ask, I know Debbie, you mentioned having a consultant to help with like the DDP. And I know that they were going to look at reimbursement rate structures for day services. Did you guys also intend as a department to have them look at non-day services and residential services also for reimbursement?
I think we plan to have them look at everything. I think our agency model is fairly solid, but there may be ways to enhance it. So, but yeah, I assume that they're going to look at our entire reimbursement structure.
Okay. Yeah, so I would just say a couple of things to point out on this that we included are, not just the wage component, but all the other things that are needed to be able to provide services, all of the supports, the training, the time off. Obviously the payment is only made when an actual service is being provided, but we know that there's lots of times where we're doing things that are non-reimbursable. And that we need to have those things in order for people to be able to do the jobs that they're doing. We have in here other things around, benefits. I think that's one of the things Teresa's group has also looked at, what should a benefit structure look like for DSPs, and whether that is that we have a rate that provides for those types of benefits that other jobs and employers offer, things like paid time off, sick leave, vacation, health insurance, dental, vision, those types of things, retirement plans. We don't really have a lot of that built into our system or current structure. So do we need to do that? Or do we need to look at, because we know that the majority of our DSPs are also eligible for benefits themselves through the state? Do we need to look at having something on there that would ensure that they are able to continue those benefits, and that they don't put those benefits in jeopardy because we're asking them to work overtime because we don't have enough staff to cover all the shifts, or we're trying to give them a little bit of a financial incentive, but that financial incentive by increasing their wages puts them over their limit for these benefits that they're eligible for. I did include, when I sent it to you, Jackie, I don't think it was in the documents you sent, but the Center for Community Solutions did a really good webinar presentation on the benefit cliff that many of our staff would experience as wages increase, where their total actual compensation ends up decreasing because they lose access to those benefits. We also included a link to National Court Indicators Staff Stability Survey so that we can see, all of our issues with turnover, our hourly wages. Also, some of the data from the hotspot survey that we did that just points to the lack of services that people are having, the inability for providers to be able to provide services to new people, and their concerns with providing services to the people they currently serve. So all of that is all stuff you guys already know, nothing really new. But I think what I also want to point out on this proposal is really getting at the critical questions, because we know that the issue with this is the availability of funding, right? If we went through and we created a reimbursement structure that appropriately compensated for the work that is being done as compared to other jobs or other types of employment that people could get, we know that it's going to be very costly. You know, a couple years ago, we were saying if we could get to $15 an hour, that we'd be competitive. Today, we'd need to be at $20 an hour or more to be competitive. And we're seeing that even in, you know, the developmental centers are struggling, and they start out, I think their TPWs start out at almost $18 an hour. Whereas our average for HPC is $13. That's an average wage for everybody, regardless of their longevity. So I think we need to look at some of these critical questions on, if we're not able to get to that, what are the other things that we can do? How do we look at how we deliver services? How can we do them and be more efficient with the staff that we have, or the staff that we think we're going to be able to have in our system? And how do we make it more sustainable? So you guys can see those. I don't need to go over them in detail, but I think this proposal has, I think, the two aspects to it. One is the compensation piece. And if some of those compensation pieces can't get to where we need them to be for what we're asking of folks, then what are the other things we can do in our system that could have that same impact? Janet, Pete, if you guys want to add anything more, if you feel like I missed something, please feel free.
I think you got it. I think it's important to look at both, right? It's how do we support what we have now? And, you know, the alternative is, you know, what can we do with the current resources we have? So
I think you did great, Debbie, and I think the something maybe for the group to keep in mind is the idea of a specialized DSP position, and that not only gets them to that benefit cliff, but like builds the bridge to the next areas. That gives us an opportunity to seek a different pool of people to come work in our field, different pay range that is more attractive to people that maybe have some specialized skills around medically fragile, around behavior support, around connecting to the community, so on and so forth. And I think it builds into Nate's discussion about the add-on piece. And I think these are all kind of interconnected in how we can maximize those add-ons to attract a new pool of people to our work, or to fairly compensate the people who are already doing these jobs. So that's my 2 cents.
So I'm trying to think about what is the appropriate next step to pursue some of these ideas. Some of it probably does flow into the overall rate setting conversation, but some of the ideas that you're suggesting could flow into, for example, like a one-time request to JFS for a waiver of certain occupations and the benefit cliffs. So there could be some other ideas embedded in here that may or may not fly when we try to push them with other people. But how would you like to proceed with either feeding your critical questions into the right group so that we start to flesh them out into some ideas? What are you thinking, Debbie? I'll put you back on point to ask.
Well, I'll be honest. I think we could spend a lot of time developing what we think the fair compensation model should be for this position. And we can do that. But I think we're going to be challenged to be able to get the amount of funding we would need in order to fund that adequately and on a person-centered level. So I feel like we need to have the other conversations and discussions. Quite honestly, this proposal was put together because I feel like these are the key conversations that we need to have. I'm not sure how it makes sense to move forward, Jackie. Okay. Maybe we do split it out and there's a group that looks at DSP compensation and what it should look like. But I don't want us to miss that we need to have some of these other conversations, that if the key thing that we need in order to compensate fairly is not going to be there, which, let's just be honest, it would be a challenge to get the amount of money. Quite honestly, like I said, if we were to go to $20 an hour, that's a 50% increase in our rates. That the reality of us being able to get that money is not there anytime soon. So in the meantime, we need to have discussions about our service delivery system and how do we use the resources that we have, how do we use the staff that we have to serve the most people within our system.
That's pivoting there. Teresa wanted in, and then Renee.
Since Debbie Hoffine shared that she's doing an RFP, though, Debbie Jenkins and Peter, whoever, I'm wondering, like, I'm thinking about Medicaid's latest RFP for reprocurement, and they're, doing an RFI first with some questions about, and it doesn't have to be this way, but I'm just throwing out there some, like, how would the people that are considering this respond to some of the questions that Debbie and Pete and Janet are bringing up? What are some of the key issues that they identify or have seen? I mean, I think that maybe if your RFP process and that rate and reimbursement discussion is going to happen. I mean, if that's the way that we're approaching the rate discussion is through an RFP, then getting respondents to answer some of these key questions as part of their response might be an approach. And so I don't know if Debbie or Pete or others could convert those concepts into questions for an RFI or an RFP that someone would have to respond to.
Well, and we may be able to do that, Teresa, but this is where I think we need to have these conversations. The reality has been in the past, whenever this type of work has been done, is that it's been done with the key component of that it's either budget neutral or that there's a limited amount of funds available. And so redesigning a system based on those constraints doesn't necessarily get us to what is the accurate compensation that's needed for these positions. And I think that's more of the issue that I see, is that I don't want to just push this whole conversation off into a process that might be limited in scope and how we can respond to it. Whereas when we need to have kind of both conversations hand in hand. And Jackie, I guess that's my thought, is I don't think we can separate out the scope of work and how do we make our system sustainable from the financial piece of it. That's just my opinion.
Mm-hmm. No, I hear you. Renee, I think, had her hand up next, and then Janet.
We were talking about the benefits and how we could make that work for DSPs. Since it's all out of Medicaid, since it's all come out of Medicaid system, I think it would be really easy to make the argument that DSP need health insurance since they get paid such low rates at the current time that Medicaid should automatically take over the healthcare insurance, not only because they need healthcare insurance, but they could get hurt doing this job. They're taking a lot of risk with no healthcare insurance. So I think it would be easy argument to make. It doesn't cost, I mean, yeah, it costs more, but it doesn't cost the DG system more. All you're doing is putting more people on Medicaid so they can get that covered. Does that make sense? Because I think that would take care. I really do think if they knew they could get healthcare insurance, you would get more people.
Okay. So the exploration of some kind of Medicaid buy-in or some kind of Medicaid coverage.
Mhm.
And I know the departments have explored things like that in the past, and it gets complicated and expensive fast, but you want to make sure that's in the discussion mix.
Shouldn't
Yeah,
that be? Sorry.
I think you would be surprised at how many people would play if they knew that.
They had healthcare.
So can I just jump in here real quick about that because people who are delivering services to the individual in their home are eligible to be tax exempt at the federal level because of IRS notice 20417- or 2014-7, which exempts us from paying federal taxes. And as a result of that, anybody, and this is going through the Ohio Shared Living Group, anybody who is doing this and has and caring for the person in their home is eligible for Medicaid through MAGI, and they're applying for it and they're getting it. Just FYI.
Okay.
What do you mean in the home, like in that?
The individual that you're serving, if you're a provider and the person lives with you and you're providing direct care services to that person, then you are eligible. Your money is tax exempt at the federal level, which also makes it tax exempt at the state level. And so we are not paying taxes on the money that we earn. And as a result of that, based on how Medicaid is set up, I think it's line 31 on your tax form that shows that it's you have zero income, which makes you eligible for MAGI, and they can actually file for it. Doesn't matter if you're earning $63,000 a year delivering services to the individual who lives with you. The bottom line is it doesn't show up on your tax form, and you get Medicaid.
Okay.
That will help people like you, but that won't help agency workers.
Okay. So I put that on the list as one that maybe a lot of people don't know about, and how do we get that out there as part of what could be a package for people. Thank you, Renee. Janet, you have your hand up.
Yeah, thanks. I was just going to piggyback on, Debbie's comments about, sort of the long and short-term goals with this, and certainly as part of looking at the rate and, really being explicit about what the current services are. We are in a crisis, and so we also need to look at what is. So, that would be my only emphasizing of that point, is that we need to have both of those conversations and see, that expectations are exceeding, what's actually available with workers. And how do we kind of do some things in the short term to shore that up? And that can mean a lot of different things. So I feel like advocating for a better rate is the thing that we all want to do, but we also have to be realistic about, how that process will unfold. And as Debbie said, how realistic it is to get us to a place where we think we would be competitive based on the types of supports that we're providing now.
So starting to, while we look at some short-term stuff, pivot to that conversation a bit, not abandon the other, but pivot a little. Okay. And I think you guys touched on that a little at our last meeting. So figuring out the right way to go about that sounds like an important next step. Okay. So I'm not sure, Debbie, if we actually, and I'm not sure, Teresa, I know you also had some longer term ideas that were discussed in your group. Is there any differentiation you'd want to point out from what Debbie shared?
I think, and others can correct me if I'm wrong, for the purposes of our discussion, if I'm hearing Debbie Hoffine say there's going to be an RFP process and then there would be a work group that worked with that vendor, whoever's chosen, I think that we wanted a work group to look at the rates. So if DODD is going to do an RFP and establish a work group, then I think that's fine. I do think it would be great if this group could influence, suggest, offer questions for response from the vendor, something along those lines, help develop that RFP
Have
and
some
something.
input into the RFP, the suggested scope of work, etc. Okay. All right. So what I think, Debbie, and I know we should all think about it for a few minutes, but I think coming out of your proposal and the conversation, some of the next steps go into that rate conversation, but maybe the other next step that we need to flesh out for this group is how do we start having the conversation about current levels of service and what may have to be adjusted based on the fact that, as Janet just put it, expectations are exceeding what's available.
Yes, I think that's the key, is that the compensation and the rate models, and that could be long-term work. I think in the short term, we need to be having conversations about service delivery and what that looks like, what those models look like, specifically what settings look like, what services are available. And, keeping this in mind, I think this was something that was brought up, I think, in our very first meeting was, as we're doing these rule changes and all these things that we're making, keeping in mind, how that impacts staff, right?
Right.
So I would suggest, the compensation work go with Debbie Halfline's group, but then there be a separate group to look at ways that we can change or look at our service delivery model system based on the resources we have available today.
Yeah. Okay. So what I'm trying to think through in my head really quick is I think maybe we just offer that as a proposal and then we'll figure out how to get on point with that, see if we have consensus. And then I think we can also go back through some of the pending proposals that we were going to look at next time and maybe do a sort as to which one of those most lend themselves to this topic. Because I think there are some ideas in the queue that lend themselves to that. Does that sound like a right game plan to folks? Okay. So if so, we're going to, we want to see your consensus vote. If you agree that we should put further exploration behind looking at the service delivery model and service packages, knowing that expectations are now exceeding what is actually available for staffing, and do we have any short-term recommendations? Is that clear? Everyone's faces are like, oh, okay. All right. So we just want to know if you feel that we should move forward with that exploration. So Jason. Sorry, I'm catching everyone off guard.
Sorry,
With
I'm on and off. Sorry.
That's all right. And you said yes?
I got to go on again. Yes.
Okay, sorry. Kristen?
Yes.
Debbie?
Yes.
Willie?
Yes.
Kim? Kim Kelly. I'm sorry, we got more than one Kim. I apologize. Kim Kelly?
I had to take it off mute. I vote yes.
Teresa?
I have to admit, I'm slightly confused on what I'm voting yes. Is this just exploring things other than the rate?
Yes, and things that we may have to do to make adjustments.
Yes. Just wanted to make sure.
We're not agreeing to what those should be right now.
Right.
We're saying let's
Just
go
the
forward.
exploration. Yep, got it. Yes.
Pete?
Yes.
Janet?
Yes.
Bethany?
Yes.
Gary? And we know it might take Gary a moment, so whenever he pops on, we'll grab it. Nate?
Yes.
Renee?
I hate to say this, but it depends on if we're talking about community or institutional.
Okay.
No, I understand that, but I mean, people who are in the community now going to institutions, I'm confused because I don't want to vote on something I am vehemently against, but
Right.
if we're talking about looking at people, making people more independent so they don't need as many services, yes, but if we're talking about putting people in institutions, no. I don't know if that hurts you or not, but
Yeah.
it's a I guess it's a qualified, yes.
Yeah. Well, and again, Renee, I hear what you're saying. I think you're making a really good point. But if it gives you any comfort, we're not agreeing to anything now. We're just saying go forth and bring back some ideas. So if the ideas come back and they're objectionable to you, it'll be clear.
Okay.
All right. Do we want to try to identify who would like to be on point for this? Or is this something you want the department to kick around? Who would want to be on point for exploring this topic? It's a big topic. And again, if everyone's not sure right now, we can work a little behind the scenes to think it through.
Well, I already have a couple ideas for ways that we could lower the staffing and to do other things so people are not so dependent on the system. If that's what you're talking about.
Yes. So
Yeah.
Renee, whatever we set up, do you want to be on that work group?
Yeah.
Okay.
Jackie, this is Teresa. I wonder, I'm just sitting here wondering, so for example, the idea of a benefits bridge, I mean, that's the word that's kind of been thrown around, has come up on a number of groups. I think it was, in an original discussion, it's come up on the DSP work group. It sounds like it was one of the things Debbie was thinking of. So are there like 2 or 3 really, like 3 people could work on building out what would go into, or what the thought about a benefits bridge would be, or 2 or 3 people would build out what would need to happen to ensure everybody had health insurance or whatever. I mean, I don't know if there are a couple, Debbie, that have kind of are top of mind, or.
Well, Teresa, I mean, we're talking about some of that stuff, but we're also talking about things like, how we serve people, right? And what group sizes and settings, how can we serve the most people with the staff that we have? So I'll be honest, I think the associations have had some conversations about this in the past. And we would be happy to, throw out our ideas, but I think these are very difficult system conversations that we need to have. And it's either we need to have them here in this group, or that the department needs to have a separate group to have those conversations, in my opinion.
Yeah, I agree, Debbie. I think it's going to be really easy for us to kind of veer away from the path because so many things are intertwined. So, I'm sitting here thinking, what's the best way to do it? And I don't know if it's, raising of hands and say who wants to be on this subcommittee. I agree with Debbie. I think all of our associations, provider associations, and OACB too, I'm sure, I don't want to speak on your behalf, but have lots of thoughts about kind of what we need to do in the short term, or what's possible to do in the short term in regards to the system. So I honestly don't know the most effective way other than to say a small work group probably isn't it.
All right. Why don't we try to think a little bit offline about the best way to tackle that, and if there's even some stage conversations or certain questions to tackle first, and loop back with that. Is that all right with everyone? Okay. But I hear you. It's like everyone that's representing someone here has wants to have a voice in that. So it'll be hard to go offline. So let's think about that one. And there might be some phone calls behind the scenes talking to some of you guys one-on-one to try to come up with the right way to go about it. Now, the
If
second
I can
proposal.
just throw out there too, I mean, to Renee's point though, I think, you know, hearing Debbie and Janet talk about different group sizes, or I think there's clearly potential for that to conflict with what Renee just said about not wanting institutional services or certain settings or things like that. And so my concern, and I've shared this with some folks on the call, is that if I just want to make sure that people here that are representing, that aren't attached to an association or a trade organization, have say in that conversation. That's, I don't know if equally weighted is the right way to put it. But I think if the conversations are happening with trade associations and that those folks on the call that aren't connected with, I just want to make sure that somehow part of the process is their input as well.
Right. Well, and Teresa, my suggestion wasn't to exclude people from the conversation, right? Obviously we're all here for a reason. But I think it may be more productive if we can work through, we'll pick on setting sizes for a moment and kind of talk about some different options for everyone to react to or have input in versus, kind of spitballing the idea. And, it's a hard topic to broach for providers, for families. I mean, this isn't the land any of us have wanted to walk into, which is why we're here, unfortunately. So, my recommendation is just to make it, hopefully, as productive as possible and maybe tear it off into smaller pieces so we can kind of talk through, that's a non-negotiable. We can't touch this part of it. But at some point we've got to look at numbers too in relationships to suggestions. Like, I can give you all sorts of feedback about what I can and can't do right now from a staffing perspective, and that's different in different parts of the state. So I think having a more kind of controlled conversation will allow us all to be more productive.
Right.
Now, of course, I don't have the roadmap for that, so I'm just throwing that out there. But that's the basis of that suggestion, not to be exclusive, but to sort of have something more solid for folks to react to, if that makes sense.
Yes. Kim?
So I hear what Teresa's saying and Janet and everybody, and I think that's great. But one of the things that I always go back to is that those of us that are actually running home care models for the home and community-based services, we all do it differently. And I think that even that we need to have some input from people who are utilizing different waivers, and whether we do this in a small focus group outside of this group and then bring it back to the subgroup that's going to be discussing this. But I do think that we need to talk to people from rural counties using different waivers and how they utilize the services within their home care model. I know for us, we mainly use homemaker personal care and nothing else because I own my own van. We work toward getting him out into the community. I mean, but then there's other people who rely on non-medical transportation and rely on, because they go to a day service or they have a job or something along those lines. And so I do think that we need to do a small focus group outside of what the recommendations are and see if it's even implementable in a HBCS setting, home and community based. Yeah.
Okay. All right, Pete.
Yeah, I feel compelled to say this, that, the reality of our situation right now, I just got an email during this that another provider shut its doors. I think we have to be careful that I think we all want the best for the people we support and try to achieve whatever they want to achieve in life. What I've seen and what we're combating right now is the striving for a certain vision for services and the unsustainability or the inability to match that want or need. I think we all want people to be successful and live their own lives. I don't think the system necessarily supports that end. So I think in our discussions amongst the associations, I know I have in my head the view of what Renee and what Teresa are talking about. I totally agree to bring all the people in who want to have the discussion, but the realities of the ability to do that on the provider end is very, very limited. So I think we always have to remind ourselves, I think we're all on the same track. It's about how do we get there and how do we sustain it long term. The reality is right now that homes are shutting down and people need services. So we're doing whatever we can to make sure that folks get those services. And it's very challenging, and that it's going to take all of us to figure it out and all of us to advocate for what we need to get those things done.
Thank you for that. Renee? Renee, did you have your hand up or was that still up from last time? I think
You're muted, Renee.
Renee, your mute button's on.
I don't. Hopefully, she can unmute.
Yeah. Nate, why don't you go ahead and then we'll come back to Renee in a second.
I was gonna say I don't think we have the ability to unmute her. I just wanted to.
Oh, yeah.
Oh, okay. Go ahead, Renee.
Sorry, Nate. When I get nervous, I can't look on the keyboard. But what I wanted to say is, I know things are going to look different. I get that. Totally understand that. We also gotta keep in mind that we got rules under the home and community-based setting that we cannot get around. Remember all those new rules that came out that you can only have so many people in a house. You can only have so many people in a certain area. I'm just pointing out that there's also federal guidelines that we gotta keep in mind when we do this.
Yes. Good point.
I just very quickly wanted to, in conjunction to all of the conversation that's already been happening, I think it's exceedingly important for us as a task force to communicate our unwavering commitment to the stability of our home and community-based services and meeting individuals and families where they are in terms of the residential setting that they choose to live in spite of the crisis that's before us. And I think in terms of non-rate proposals, in terms of building resiliency, there's a lot that can be done. I know that someone had resent out the recommendations from the Ohio Olmsted Task Force from 2 years ago, and one of those recommendations really focused on educating individuals and families how to on how to work with providers in the process that it is as far as an advocacy standpoint. And I'm wondering what that looks like in official policy from the department. I don't know if long term there might be, you know, something that can be done with community integration add-ons that providers could use to support this type of education. and what the department can do. Maybe I'll develop my next proposal will focus on things that we can do around advocacy to build resiliency in the system with individuals and families so that they are empowered to take ownership of their provider situation. And if they don't have staff, what can they do on their own or with their natural supports to decrease that reliance and figuring out those with the tools that we have available?
I think that's an excellent point, Nate, because I think one, we have to use all the tools in our toolbox, right? And is it a reality that we as a provider system can't serve everyone that we serve, or can't serve at the level that people want? We're going to have the support of the communities. We're going to have the support of family and friends. It has to happen. I don't think we can sustain our system without getting out of our own bubble and asking for people to step up and help us out.
But,
Go ahead.
but along with that, Pete, you said family and friends, but you're excluding the fact that individuals themselves are capable of doing more, but they've been taught that they can't.
I agree with you. I think we haven't tapped into potential or what is possible for a lot of people in our system. If I'm understanding you correctly, Renee.
So I'm going to put a little point on this piece of the conversation because I'm keeping an eye on the clock. I think we have a challenge on how to move forward with that workforce, but we'll sort that out as quickly as we can so we can start getting some more specific proposals in front of everyone for reaction. To Janet's point, I think there were some other ideas that we might be able to tease out of the reports today and turn them into proposals for next time. So we'll go back through everyone's notes more thoroughly and check in with people to see if we should tease some of them out and pursue them separately. I wanted to give time. Two folks had asked for a few minutes. So I wanted to give Kristen a second. She had wanted to give everyone an update. She'd been working with Pete, Lori, and Willie on a guidance document, and she wanted to share with you. So Kristen.
Thanks, Jackie. And I just want to say thank you to those three, to Lori and Willie and Pete, for the conversations we've had. So the discussion that we've been having, and as I said to Jackie when I asked for some time, is this is not a proposal in that we're not asking for this group's consensus necessarily. We're not asking for DODD to do anything. But as an aspect of all of these discussions that we're having and some concerns that we have about kind of how shortages play out on the ground, we as our organizations wanted to come together and provide our recommendations or perspective to the field. And so the document that we are in the process of creating is in some ways a follow-up. It's kind of formatted similarly to the Trusting the Team process document that we produced with a couple of other organizations about a year ago, focusing on COVID issues. And so what this document is doing, and it's still a draft, which is why we haven't circulated it, is kind of two sides of the same issue. How the conversation started was our organizations agreeing that in situations that there are there's a home that can't be staffed or whatever it is, that there are certain needs of individuals in our system that I think we all recognize are the highest priority. As I think is along the theme of a lot of things we've been talking about today, an HPC service, it looks different and means different things to different situations. And so if there's a situation where we've got one staff person and they either need to go to this home or this home, what are some of those higher priority needs? So that is an important part of our document. And then the other part of the document tries to give some encouragement to county boards as a group, providers as a group, and then individuals, guardians, and families as a group on what are some things that they can be doing to try to prevent an individual crisis. So let me go ahead and share my screen if I'm able to, if I have the right permissions, hopefully. Here it is. Okay, so hopefully you're all seeing that. And so we're still working on a title and formatting and all of that. But basically what we go through here is that there are workforce shortages that are challenging teams to make difficult decisions, that we want to put some recommendations out there. And one thing we really wanted to emphasize, which we talk about here in the middle of this first main page, is this is not intended to be a suggestion that everyone needs to immediately change every ISP in the state to anticipate a shortage in an individual setting for one person, but that people need to be prepared to make these decisions, prepared to assess those highly critical needs when the need arises. And then we also really encourage throughout this document good communication between all of these groups. And so that's encouraging county boards to be proactively in touch with providers in their area. It's about providers being proactively in touch with county boards when they know that a problem might be coming up. And then for everyone to be communicating with those individuals and guardians, because I know at least at APSI, we've certainly had the experience where a county board and provider have been addressing maybe a home closure or something like that, and we're among the last to know, instead of individuals, families, guardians being brought in earlier to understand what's happening, to know what the options are, instead of being told basically you need to move. So really encouraging all of that communication. So then here on the last or next two pages, like I said, we've got some of these bullet points for county boards as far as being prepared for urgent situations, having designated contacts, crisis response plans, providers assessing their own capacity, projecting shortages might occur, and individuals identifying what are my highest priority needs, what's going to be a real emergency if staff doesn't show up, and how do I know who to contact about that. And then this on the right side of the screen is some of those, what we've identified among our organizations in consultation also with a doctor who addresses some of these needs, trying to identify what are some of those high priority needs or high vulnerabilities for individuals that, you know, if staff have to be allocated somewhere, you know, people need to be able to eat. They need to be able to do basic hygiene. They need to be able to get their medication, their wound care, things like that. Supervision is always, I think, a tough one. And I would hope that in these discussions we were just having about kind of looking at how our system is structured, you know, I think supervision is a big part of that. And so we talked about, you know, supervision for self-harm, for wandering or elopement or unstable mental health conditions. And then we tried to remind people about some of the other alternatives that are out there: technology, natural supports, as we've been discussing, and adjusted supervision levels. We did a couple of resources and then a conclusion there. So like I said, this is something our organizations in the near future are planning to finalize and then publish. If anyone else would like to get drafts and sign on or consider having your organization sign on, please just send me an email and we can loop you in. We would really welcome having more of a collective voice than our three organizations. So Willie or Pete, Lori, anything you want to add to what I've said?
No, nice job. Thank you, Kristen.
Yeah, thank you, Kristen.
Yeah, I know Kristen's she's done a fabulous job here and kind of helped spearheading this. And we like the fact that from an advocacy perspective, she understands on the ground that these tough conversations will have to occur and are occurring. And that this would be a resource for teams to use when they simply are looking at what kind of conversations do we have to have with families and guardians that may be difficult. And this will at least, I think, provide some resource around that. It's really it's a triaging sort of thing, and that's kind of the place that we're getting to be in the short term. So thanks to everybody who's working on this with us. And I would echo what Kristen said. If Ohio Healthcare or VFA would be interested in taking a look at this or signing on, or anyone else, we'd be grateful. So thank you.
So, Kristen, this is Teresa, and I haven't seen the whole document, but I think I was thinking about the suggestions that Renee and Nathan were having, and so even adding that perspective of, as the person, as the central part of the team, the family is a central part of the team. What, like Nathan was saying, what are your other options? If or how can you develop natural supports, or how technology could meet a need, or something like that. So I think some of the things that Nathan and Renee were talking about could be really beneficial from the perspective of the person on the team, or the family.
Okay, Kristen, thank you. It looks like a lot of really good work.
Thanks.
Appreciate that you shared it with all of us. Pete also asked for a few minutes to talk about a couple of ideas that he had, or he's working on, or that he wanted to float. So, Pete.
Thank you, Jackie. We've talked about briefly in some of these meetings about the number of providers in Ohio, and I know there's been a county or two that has mentioned that the number of providers in their county just keeps growing, and it gets tougher and tougher to manage. And given the current workforce situation, the number of providers continues to grow, and it continues to thin the number of people that can work for any given agency. So, or independently. So I would like to start the discussion again. With 9 minutes left, I always bring these things up at the finish line, but it's not my fault. No, I'm just kidding, Jackie. I think we need to seriously take a look at regrouping as a system in Ohio, and the possibility of freezing new providers, or allowing new providers unless there's very special circumstances, so we can regroup a bit, understand how many active providers we have, understand the status of those active providers, meaning where they are with revocation or 3-year certification, so on and so forth. This has come up a lot in our membership as far as, I know it probably sounds weird for a provider association to even bring this up, but we've talked a lot about the idea of, should we just freeze the number of providers where we're at right now for a certain amount of time, so we can regroup and understand where people are and what the future looks like as far as our ability to provide services in the future.
It's not up for a vote, but I'm voting yes.
Kim?
Are you talking about agency providers or independent providers as well?
I'm talking about both, but
wow.
But like I said, I said there may be situations where that's just not possible. I'm talking, we've been doing a lot, for example, to promote independent providers, but as we found out through the pandemic, there's a lot of independent providers that aren't providing any service. Right.
And we understand that, Pete, but there's also a fair amount of independent providers who are family members who are going to be providing direct care services to the individual who is receiving their services within their home. So I'm a little concerned that we don't carve them out if we do put a hold on. I mean, I'm not opposed to it per se, but I do think that we need to somehow look at the number of people who already have clients that they're going to be serving. and maybe get that through.
Yeah, I don't want to be misunderstood here. I think I agree with you. It's more about taking a look at situation by situation. I'm not trying to stop a family by any means to support the person, their family member. Not at all. What I'm saying is for all those, what's the activity level for all providers out there? How many providers have shut their doors throughout the pandemic? How many are on the verge of that now? Just getting a handle on where we're at, so we can look towards the future and what our system could look like. What's our capacity issues? What's the capacity issue?
This is Lori Stanfa. I want to echo what Pete said. We put a proposal forward to the director several weeks ago from Cuyahoga County in this regard. I know Jason Abadili, this is one of your proposals that you've submitted, and we are prepared to have the conversation. I would hope in some detail at our next meeting about what this would actually look like, what the parameters would be, as Pete said. Are there carve-outs? What would the mechanism be? That sort of thing, so we can get moving on this sooner than later. So that would be the OACB position.
So we do have a
I think Kim brings up. Kim,
I'm sorry.
I apologize. Genuinely apologize. It's hard when your phone is duplexing. Kim brings up a really good point, and I think what Pete and Lori and I've been saying for years, quite honestly, it's an ideological change. It's not a one size fits all. And Kim brings up a good point. This is an idea that needs to be flushed out, but we have got hundreds of millions of dollars that could be redistributed based on the fact that we have too many providers. We may actually have too many county boards, if you want to be honest with you. Maybe we don't need as many county boards. There's lots of money in this system that is being spent on non-direct care related issues, and positions and people. We don't like to talk about this, but it's a reality. If we're not going to get more money, let's use the money we have in a more efficient way. But Kim, your statement is a very important one, because that is not at least it's not mine, and I won't speak for Pete. I don't think it is. That's not the impetus for the suggestion, is the families and independent providers taking care of their own loved ones.
So we have a couple of people with questions. I know we're coming to the end. I would propose, I know, Jason, that you do have a similar proposal in the pipeline, that maybe you and Pete look at that to see if it's worded the way you want it to be. And then we, can have that be part of our full agenda next time, if that sounds acceptable to you guys. And then Nathan, I know you had your hand up next.
Mute. I just wanted to support or endorse or agree with Kim's comments and say that maybe this type of approach, as we flesh it out, maybe it goes down two pathways. Maybe there's an approach for agency providers that we take and an approach for independent providers, because we still want to, if an individual as someone who's willing to support them as an independent provider and come in the system and address an immediate need, I think we need to be flexible enough to accommodate that.
Thank you. Teresa, I see you still have your hand up.
Yeah, same basic comment. I mean, I think especially for people that are using independence right now, and say somebody, their independent provider leaves, goes off to college, and their neighbor is willing to provide the service, would we really say, no, you can't become an independent provider, you have to go find an agency or somebody that's already certified as an independent? That just doesn't make sense. So yeah, thinking about how, I mean, we tried to certify capacity when we changed adult service rules, and people didn't like it then. So I'm fine with thinking about it, but I just think, yeah, for independence and families, and shared living would be another one. If you find a family that's willing to do shared living, and we can't certify any new shared living provider. So I think, like Lori said, figuring out the parameters or carve outs or whatever it might be would make sense.
Thank you for that. Renee, I'm going to give you the final word.
I echo what Nate and Teresa just said, and I'm going to be really careful with using the words family as provider, because I have no family. So my independent provider are not going to come from families. So we have to be very careful when we say family.
I agree, Renee. And what we've also said, Amy Clausen is one of the people that's on board with this, and we're not only just talking about families that want to become IPs, but we're talking about anybody who wants to become an IP that has a client in the pipeline to serve once they get certified. I think that's clarifying it on all settings, right?
Yeah, we would support that, Kim. This is Lori. We agree with that.
All right, so we will take this. So much for Renee having the last word. So I think
I always get the
there you go. So we will take this up as a proposal next time we're together. It sounds like maybe we're on our way to some consensus here, but we'll try to talk it through more thoroughly next time if that's good. So I'll try to get the notes together. Jason's going to follow up on the incentive proposal. We have to rethink how to talk about the service package to meet workforce, at least in the short term. So we'll figure out a methodology for that. Pete's going to work with Jason on this idea of freezing and have that proposal ready for next time. I also believe, following up earlier when people wanted to know more about unemployment comp and how that was impacting the system, I believe Steve was able to set that up. Steve, I don't know if you can unmute, if we've got a date or if you're still in process on that.
No, we've got them confirmed for our next 1 hour meeting. So on August 11th, they'll come in and provide us with some information, a presentation, and be available to answer questions from the task force.
Okay, so we'll follow up on that. Our next meeting is right now set to be an hour. We'll keep working with all of you if we need to extend it a few minutes so that you can also field the proposal we were just talking about. Any other next steps that I need to identify? Okay. I appreciate your patience with me as we started really working through them. I feel like we're starting to get in a rhythm, and we'll keep moving going forward. I welcome any suggestions that you want to throw my way, and also any new proposals, or if you've already submitted a proposal and you want to refine it, just submit them to me and I'll make sure they get in the pipeline. Let me throw it back to Kim. Is there any final thoughts from the department before we go today?
No, I just thank everybody for being here and the great conversation today, and look forward to kind of processing it all.
Lot to process. It was a really rich conversation. Thank you all for everything you're doing in such a difficult time. We are next set for August 11th, but I'm sure we'll all be seeing each other between now and then. Thank you.
Thank you,
Thanks,
Jackie.
everyone.
Good job.